Good afternoon, everyone. At the outset, I would like to thank AIOCMT3 committee for this opportunity. So, the slides are not moving. Slides are not moving. So if we go a little more than a decade ago, we used to have these kind of images where we used to have a little bit of fluid with a little bit of RP mottling, and then we used to give injections, and then there was basically no result. And this was known as an occult CNVM with these kind of petite kind of leaks over there. ICGA used to never show anything, and then you get an RP tract over there, confusing us even more as to where we are going. And then it was OCTA which was introduced, and we could find these really nice patterns over there. And again, the slides are not moving. So then we had, then there was the introduction of the swept source OCT, and something known as the thickened choroid came into view. This is when we got the Plex Elite machine, which very clearly defined what CNVM network actually looked like. And then rest is history. So what is OCT angiography? OCT angiography is basically a non-invasive technique, basically using motion artifact to motion contrast to give volumetric analysis of the retina, layer by layer, section by section. So you can basically go from the superficial retina to the deep, then to the deeper layers, and finally the choroid. So as we go with NFAS, we also need to see the B-scan images. The B-scan also kind of became better, and from a 9 mm scan, now we have a 16 mm scan, which is kind of standard. As we go deeper, we also go wider, and now we can almost image almost 80% on an NFAS with almost 22 by 22 mm scans. So coming disease by disease, what has OCTA really changed? So coming from the superficial to the deep capillary plexus, if you see these diabetic patients with not much edema but the vision not improving, you'll have these diffuse leaks but you will not know what is happening. And that is when you see at the deep capillary plexus where you see ischemia. Second is, you have these small tiny leaks over there, confusing between IRMAs and between an NV or a tiny NV, but OCTA picks it up very well. If you see at that kind of, if you see that red arrow mark over there, you pick up a very small, tiny NV. This basically redefines the way that we look at OCTA and look at FFA. This patient, which is a diabetic with a kidney transplant, obviously can't do an FFA, but if you look at a color image, there are just few hemorrhages, probably labeled it as an NPDR. But if you do a wide field OCTA, you will kind of realize that there is an NV over there, which totally changes our diagnosis and the treatment plan. Images like people with, again, PDR, where you do suspect PDR, but with nephropathy, again, FFA is challenging, so OCTA plays a very good role with these large networks and CNP areas, which can be very well defined. This can also be, it's not just that we are picking it up, but it's also been documented that you do see a decrease in the leaky patterns and also decrease in the networks that you pick up on FA as well as on OCTA. This was something that we did in our center, and we kind of documented this decrease on NVD. Vascular occlusion, again, this is something which you can see CNP areas, you can study the FAZ on OCTA, but what is more very, very defining about OCTA is the change from non-ischemic to ischemic. Okay. So which can never be picked up on a fluorescent angiography because of the hemorrhages. And OCTA really delineates it very well as we shift from non-ischemic to ischemic CRVO. Images like these where there's a featureless retina, there is the B scan looks absolutely normal, but then these patients usually have systemic problems and FFA becomes a challenge. But then doing an OCTA where you see this gross ischemia, tells us where to head towards a treatment. There are newer protocols of imaging, classifying where they have a color-coded map for OCTA now, and maybe in the near future we'll have a new classification system as well. We also tried our hand at color coding, and we came up with this beautiful image of an NVD. Going more deeper, I think we go deeper into the avascular, the choriocapillaries, and the choroid. So OCTA is really defined the way we look at CNVMs, how we see the different networks, most commonly the medusa and the glomerular one. And if you compare it with the B-scan, we can also characterize them as type 1 or type 2 CNVMs. RAP is one disease, again, which was extremely difficult to diagnose till the time OCTA was not there. You used to get these cystic lesions, and you get these diffuse leaks over there. And then finally, when these cystic, when OCTA came in, it was very, very clear how you could trace the vessel from the superficial to the avascular to choriocapillaries, ultimately to the choroid. This is a typical CSR, and this, I think there was no confusion many years ago. I was just given probably an eplerenone and a Cobadex and sent the patient home, but then nothing used to happen, and that is when OCTA kind of helped and picked up that tiny lesion over there and changed the way that CSR was also diagnosed and treated. Multifocal CSR, again, there are various numerous theories which have been put into various treatment protocols, as much as rifampicin also. But ultimately, OCTA changed the way that we look at it when we pick up a network over there. IPCV, I still feel, is not something that should be diagnosed on OCTA. I think it is safer to say, because they are low flow lesions, so I think safer to say than that ICGA probably is the better modality to pick them up, but you can pick BVNs better on this. But then what do you do about this? So this lady has been on a treat and extend plan for the last many years on 2 monthly, but if you see, the BVN is still increasing, there is no fluid over there. So maybe OCTA one day will redefine the way that we also treat and extend in these kind of BVNs. Coming to vitelliform, this was just an egg yolk story until unless OCTA started picking up networks, and you could see the change that it has brought about in the treatment modalities for this. ILM drape sign, that was the most common word, and there was no treatment for this many years ago. But now that we see that, why do different patients progress differently? Because there is always a tiny network. Sometimes there's a tiny network there which needs to be treated. So how about wide field choroidal imaging? I think pachychoroid neovasculopathy is a disease which has been defined by OCTA, and it gets resolved very well with anti-VEGF monotherapy. PHCR this is a study which was done by our group, and especially Dr. Darius and Dr. Meenal, where a normal choroid will be thicker subfoveally, whereas in PHCR people, you could see the choroid to be more thicker at the place of the lesion. So basically PHCR now is a part of pachychoroid. SSOCT in PDR, one of my favorite topics. I think the blue arrows typically show the posterior leaf of the vitreous cortex, and this is where you need to undergo, where you go under with your scissor or forceps or the cutter, and that makes these tough membranes very easy to take out. Full thickness macular holes, very small hole, very beautiful to look at, but what would be more beautiful is to image them the next day, and what again changes the way we position the patient. So to conclude, I think wide field imaging has really changed the way that we have defined a few diseases, not all. But yes, it is a modality which is non-invasive, so it can be repetitive. But understanding the images, sectioning, and artifacts is extremely important. So I'd like to close with my line that even a myopic view needs to have a wider perspective, and hopefully very soon we'll have scans like these. Thank you. Now we have 24 by 24. Plexelite gives us 24 by 24. So basically a 24 mm by 24, and most commonly a 15 by 15. But then wide field, I think 15 by 15 is the maximum that would be with lesser artifacts. So roughly around 80 degrees is what we are kind of going with OCTA.
So is FFA is obsolete, or it's
not at all? Not at all. I personally, I do feel that every OCTA image should be corroborated with an FFA. Because it's not like you can just pick up an OCTA, because OCTA will not tell you a leak. OCTA will just tell you a lesion. Probably only with nephropathy patients, CSR and PHCR. These are 3 diseases where probably OCTA has played a major role. And also in surgical nuances, as I showed in SWEPSO, OCTA, I think has played a very major role. Yeah.
Okay.
Not at all, sir. It is not. It is just an additive, and basically it kind of improves our understanding on certain things that we didn't have, like I showed IJT, and then even CSR. So it's totally changed CSR. So I was asked a question once that, if you don't have an OCTA in one clinic and you have an OCTA in another clinic, what will you do? I said I would not shift other than for CSR, maybe.